Everybody wake up. It's a brand new day, and this is your chance to let your soul shine. Proud to be you and me, freaks and geeks. Always remember that your soul is divine. Come on.
And welcome back to the little project I like to call Lary Talk, folks. I am your host that has no throat, but still kind of sounds like Harvey Firestein. Henry King. How's it going, guys? And welcome to the Head and Neck Cancer Awareness Month, folks. Now, a lot of you might not even know that's happening right now because sadly, there's not a lot of news coverage about it, which I find pretty sad. I think every cancer that has a month should get recognized, no matter what it is. But nowhere in the media. I've been trying to do my part. We've emailed a few news outlets, and we're on Twitter now. If you look up Lary_Talk, you can find us on Twitter. And I got in trouble for spamming and bullying news outlets. What I was doing is every time they were reporting on Chris Rock, I would reply with, it's Head and Neck Cancer Awareness Month. And yeah, so that got me in trouble. But the account's unlocked now. Everything's settled. It's fine. I won my dispute with them, which is weird. Like, I get to rare cancer. 4% of cancer is head and neck cancer. You see what I mean? 4% out of all the cancers, still a lot of people, man. Just under, what, 200,000? So that's a lot of people. And it's something that should be recognized because it's not just a laryngectomy that you're going to have if you have head and neck cancer. You know what I mean? There's a lot of things that can go wrong. It could be on your tongue, could be in your ear, could be in your sinuses. That's why it's head and neck cancer, okay? This show focuses mostly on a laryngectomy and reminds you people all the time that, like, you don't need to smoke to be a laryngectomy. I don't know. Truth.com ruined that for us, man. They totally did us wrong on that. Because when somebody on TikTok sees me or anybody like me, they automatically make a cigarette comment. It's like, some people did smoke, man. You know, oh, well, next time you'll think before you smoke that cigarette. Okay. Well, I'll tell a 14-year-old child that never smoked and needed a laryngectomy not to smoke. It's weird. It's weird how this cancer is treated compared to others. You know what I mean? It's really just, you wouldn't tease anybody with leukemia. You wouldn't tease anybody with pancreatic cancer. You wouldn't blame something on it. You would just be like, oh my God, you have cancer. But for some reason with us, they're like, oh, smoking. And I blame truth.com and other things because they kind of misled the public a little bit, including myself, man. When I first heard of this, I'm like, oh yeah, it's from smoking. And then when I studied it more and got into it more, speaking to other laryngectomies, people had never smoked at this. People had never smoked at lung cancer, you know. It's in our DNA, folks. Cancer will pop up and it just happens. So keep that in mind. So kicking off Head and Neck Cancer Month, I actually get to interview an SLP, Kerry Lenuis from, she's got a PhD and she's out of Florida, I believe. She contacted me earlier in the week asking if I needed to interview an SLP, and I, of course, said yes. Sorry about that. Very nice lady. It was a great interview. We went over a lot of things from, which you'll see, anywhere from like getting your tip, what to deal with when you get it, when you're cleaning it, if it's leaking, that kind of stuff. I will say I wasn't on my A game on that. When we recorded it, it was like 9 o'clock last night. I was exhausted. We had a bunch of stuff go on during the day, and yeah. So my A game was not there, but she did a great job. She answered all the questions. She was patient with me. And I thank her for it. You'll see the interview here in a little bit. You will also notice that if you're watching this on YouTube, thank you for watching. Please hit the like and subscribe button for me. But if you're watching the video format, I am not wearing the same thing I wore when I did the interview last night. 2 reasons. One, it's cold right now. Yesterday, it was like 70 degrees here. And today, it's like 40. And I don't get it. And I don't want to sit here and freeze just to make something look sync. It's not my bad. We don't record this live. There's no way I could do it live. Every time you see a cut, if you're watching a video, that's usually because I had to spit. Talking long periods of times actually causes phlegm and so I end up spitting a lot. Nobody really needs to see that, right? Nobody wants to see that. I don't even want to do it. But before we get into all that, let's do the normal thing. Gonna promote Aaron Wayne's book like we normally do. The Silent Partner, my first chair is a laryngectomy. It is his take on becoming a laryngectomy, his journey through the diagnosis all the way up to surgery. It's not filled with a bunch of scientific facts and all that stuff. It's an easy read. It's got humor into it and a little bit of heartache, all that good stuff. All the stuff you need to make a good book, and I like it. It's an easy read. You can read it in a couple hours. Then there's nothing in there that's going to scare you. And if you contact Aaron, he might be nice enough to send you some stickers. If I go on your HME, I've never really showed you guys up close. See, that one says panic. That one's just a power button. This is the one I'm wearing today. It's our ribbon, burgundy and ivory. And it says the strong silent type with silent X'd out because I'm far from silent. I haven't shut up since I got my type. This one just simply says O2. Gonna get patriotic with the flag. And he's got a bunch more, man. He's got one for every holiday and all that good stuff. He might even make one custom for you. You never know. So there you go. Contact him. Or you can get the book on Amazon if you want to help him out. Maybe buy it. And go from there, guys. So like I said, this week's episode, I got an interview with an SLP. So I'm not really going to go on and on with my part. The interview is more important, I think. Much like every time I do the interview, it's the interview is the most important part of it. The one thing we didn't mention last night, I think it slipped both of our minds. Say your tap is leaking, right? And you got a slow leak that's around it. And you know it's not like it's a failure. You need to get a new tap, right? But you can't get in there for a couple days. And it's a small leak, and that's something that you're really, really worried about. Go get you a can of Thicken Up, okay? It's made from Nestle. You could find it at any pharmacy, any of your grocery stores. What this stuff is, you put a little bit, not a lot. Follow the directions, trust me. You put a little bit into a liquid and it'll thicken it up for you. There's no taste to it. It absorbs whatever flavors you're using. So you can put it in your coffee, you can put it in milk, you can put it in whatever. Follow the directions though. When I had a temp leak, I used it because mine happened on a Friday. I couldn't get in there until Monday. So when that happened, I got this, and I made pretty much damn near a milkshake. I think it was 2 teaspoons I used, and it thickened it up crazy thick. Like I was eating coffee. It was insane. So it's a good product though. When you use it right, it's a good product. They will thicken it up so it won't leak as bad, if any. And you're still able to drink. You're still able to hydrate yourself. It's very important. So with all that said, let's just get to the interview and go from there. And I'll see you on the other side. Welcome to the Lary Talk exclusive. And I'm here with an SLP, Kerry Lenuis, who has a PhD. How are you doing today, Kerry?
Great, thank you.
Let's get right into this. Where are you from?
Currently I'm in Gainesville, Florida. I was born in Massachusetts, but I live in Florida now.
And what did your parents do for a living?
My father was a small business owner and my mother was a teacher.
And did you have any siblings? And if so, are any of them in the medical field?
I have a sister. She's not in the medical field though. She's in sales.
Right. What made you get into the medical field?
Well, I think it was more of wanting to get into speech pathology. And then from there, decided I wanted to do the medical field. When I was in high school, I thought I'd maybe like to be a nurse, but I didn't really want to be around blood. So I thought, hey, maybe speech pathology would be the way to go. I could be, in the hospital too. Mhm.
Right. So what made you choose to be in a speech pathology as your go-to for the career?
Yeah. So I was really close with my grandfather. When I was in high school, he lived with us for a few of those years. And he was very hard of hearing and very motivated. So he taught himself sign language. And I try to learn some as well. So communication disorders is our undergrad kind of umbrella. So audiology or speech pathology would get the same undergrad degree. And so I went into that. I was actually a declared major when I was in high school. I said, that's what I want to be. I want to be a speech pathologist. And I, never changed majors, which is pretty unusual.
Yeah. Almost everybody I've ever heard going to college changes at some point. So
Yeah.
Was there anything else you were interested in doing, like other than just the nursing portion?
Yeah, not really. At one time, I thought it would be nice to be either a neurologist or an ENT, but I didn't really want to go to medical school. So,
Right, I don't blame you there.
yeah.
What is the most challenging about your job?
So I'm actually a supervisor. So I supervise the other speech pathologists at the hospital. And then I also see patients. So probably interacting with my employees, some of that employee management stuff can be challenging at times.
Right, doing all scheduling and all that. Yeah.
Yeah.
Okay, what is the most rewarding about your job?
Definitely seeing the patients, being able to see people make progress. One of my favorite types of appointments is seeing a laryngectomy patient after they've had their prosthesis inserted. In that first follow-up visit where I teach them how to clean the prosthesis, we hear their voice. As long as they get that voice, that's a really cool appointment.
Yeah, the day I was able to use this it was so emotional. Like the first thing I did, like I was trying to do my ABCs. And then as soon as I figured out I could do that, I just ran to my wife and I love you, and we both cried like little girls for a little bit. It was a good time.
Yeah.
It's well worth it. Okay. What would you say is your biggest achievement in both career and life?
For career, I would say getting a PhD. That took, several extra years. For speech pathologists, we don't have to have a PhD. So that was something extra at that point in my life. I thought I was going to go into research, but I've stayed clinical. But that was definitely an achievement for me, is completing that degree. And then personally, having a family. I have 2 children and a husband, and that is, they're my pride and joy. So, yeah.
Right. Everybody has the common answer. It's always the family. So it'd be kind of selfish if somebody was like my Ferrari.
Yeah, I don't have a Ferrari, so my minivan is really cool though.
Hey, minivans rock. Okay, so here's the tough questions. We call these the Lary Top 5s. What would you rather have, a burger or a pizza?
I do like both, but I'm going to go with pizza.
Pizza. And what is your go-to ice cream?
Mint chocolate chip.
And what is the movie you've probably seen the most?
So this would be when I was younger, but if you recall the movie Say Anything, I used to watch that frequently. So I've probably, if I had to count how many times, which I can't, that's the movie I've probably seen the most.
And what do you think is a better pet, a cat or a dog?
So I've had both, and I would say a dog.
All right. And what is your favorite music genre?
Pop.
Pop music.
Mm-hmm.
And I'm going to assume you grew up with 80s music, right? 80s and early 90s, right? Back when pop music was actually really, really good. Okay, so now we're going to get into the portion. It's more about your career and what you do. So when the Larys meet an SLP after surgery, we make a kind of association with an SLP and with cancer patients. when other people think about hearing an SLP, they think of like child development and other things like that. So as someone who speaks, teaching language and that kind of thing, can you explain what your field is and some of the different things you guys do or would be needed or advised for?
Yeah, so it is a pretty broad field. You're right. A lot of people think of child development or school-based speech pathologists. I wouldn't even be well equipped to be a school-based speech pathologist because that's not the area I've been working in. But our field is from birth till end of life. So some people work with newborns in the NICU. So, early because of swallowing, so feeding concerns and communication as well as they get a little bit older. Working with people who have dyslexia, so reading difficulties is fairly common in some children. So some people specialize in that area. I used to specialize in aphasia, which you may have heard on the news recently. His name, Bruce, his name is escaping me, but somebody.
Die Hard, yeah.
Yeah, Bruce Willis.
Bruce Willis, there we go.
They came out, he was diagnosed with aphasia. So aphasia is a language disorder in adults. So after strokes, that's very common for us to work with people for speaking and communicating, as well as swallowing after things like stroke or Lou Gehrig's disease, so ALS, or other diseases that can impact people's ability to communicate or swallow. And then of course head and neck cancer, not just laryngectomy, but glossectomies, radiation to the mouth and throat regions. So there are many different areas people might work in. Heart disease is even one you might not think of. So if somebody has a heart transplant or a lung transplant that interferes with nerves near that are very important for the voice and for swallowing, right? So we work in those areas as well. Yeah.
Yeah, I never even thought about that one. Transplant portions.
Mm-hmm.
Yeah, so it's a huge variety, and I think you guys have to like pick which one you want to go for. You know what I mean? Like with oncology, I imagine you're picking which kind of oncology you want to work on, specialize, like if you want to be like an head and neck cancer, that kind of thing.
Right. Yeah. So kind of the job that you pick, some jobs, even with ENT, if you're an ENT in a rural area and you're the only ear, nose, and throat doctor, you're going to do some of everything, right? So it's kind of like that for speech pathology too. Say you're a home health speech pathologist in a rural area, you're gonna just kind of do everything to meet the need. I happen to work at an academic medical center, so we do have more ability to specialize where there's enough patients, say with laryngectomy, that I can really kind of specialize in laryngectomy, whereas someone in a rural community might see 1 or 2 laryngectomies their whole career.
Right. That's why I keep reminding them. Is like you see a bunch of laryngectomies get mad because nobody knows about us. It's like, if you live in a small town, you might be the only one within like 100 square miles.
Yeah.
I think there's only like 3 of us in my entire county, and I've only met one. The other one, I heard him in the distance, but I couldn't find him. Mm-hmm. Okay. Where was I here? Okay, so we'll get with the laryngectomy portion of this. How soon after surgery would you meet with an SLP?
So I like to meet with everyone pre-operatively, and then post-operatively, we aim for post-op day 1. And that's because we're fortunate to be able to have the laryngectomy pulmonary kit for our patients. So the speech pathologist is the one that goes in post-op day 1, opens up the box, puts the batteries in the electrolarynx. Otherwise, it would all just sit there. So we kind of attend to those things, put it in the person's hands, let them start trying to use it, reminding them of some of the things we taught at pre-op about the HMEs, things of that nature. So that's when we target post-op day 1.
And would someone see an SLP if they did just radiation and chemotherapy? And you've already answered this one kind of, so.
Yeah, absolutely. So especially if it's laryngeal cancer, right? Because that's going to target all of that radiation right to the voice box, which is going to impact swallowing. So people who don't have the laryngectomy surgery but have radiation do often develop swallowing problems. Remember, their anatomy isn't changed like a laryngectomy, so they're more likely to have things, go down into their airway, into their lungs, because the connection is still there from the mouth to the airway. So we teach them exercises to try to prevent difficulty throughout radiation and afterwards.
And what are some of the things that Larry will see an SLP for? And are they everything done in the office?
So you mean like different types of appointments?
Yeah, yeah.
Okay, so for us, everything would be done in the office except for swallow studies. So if we're doing a modified barium swallow study, that's done in radiology. So that would be done commonly with the laryngectomy, especially post-operatively, to make sure everything's sealed and see what kind of food people can, start taking again, as well as later down the road, if someone develops a new trouble swallowing and they're a total laryngectomy, we usually have a concern that they might have a stricture or narrowing in the esophagus. So we would do that study for that. In the clinic, anything you can think of as far as pre-op visits will be in the clinic, speech evaluations post-operatively, working for therapy, doing the electrolarynx, doing if somebody's working with esophageal speech. We don't have a lot of esophageal speech users, but we do have some, and I have coached some people in esophageal speech. So electrolarynx, esophageal speech, or the voice prosthesis as well. If we evaluate people before our surgeons will do the secondary puncture for the voice prosthesis. So we do that in clinic, and then we see them post-operatively and change their prosthesis in the clinic too.
Swallow test is like the coolest thing to watch. Like to see everything working of it, the mechanics was pretty cool. I thought that was an awesome thing. It sucked that I had to see it, but it was cool. Okay. How did the shutdown in 2020 and beyond, it seems, how did that affect your job? And have you seen any of your patients' faces?
Yes, I do see my patients' faces again now, but it did have an impact at that time in the height of the pandemic with the first wave. The hospital actually shut down outpatient services for about 2 weeks, which might feel like, oh, it's only 2 weeks. But if you're someone whose voice prosthesis started leaking early into week 1, it was a long 2 weeks, right?
Right, especially if it was like complete temp failure, that would just.
Yeah. And even our ENT surgeons were not able at one point in time to do the surgery. So someone might have a large laryngeal cancer that, is clearly they need to have surgery and they'd have to wait. Or even, tongue, jaw, lip, other cancers as well. Those people did have a delay because of that. Yeah. But nowadays we are able to see everyone in clinic, in person. We're not doing any virtual at my hospital. We do wear all of the protection, and then the patient can take their mask off.
Right. Went through my experience during the shutdown happened about a month before that. So I went through that whole thing during lockdown, and it was horrible. At the same time, it was nice because I was able to avoid people during my chemotherapy pretty easily. So,
but then after, when everything opened back up, there was a backlog. So then trying to play catch up.
Yeah, what was great about it is when I went into the office, I'd be in 15 minutes. It was great. And then after everything opened up, it was a 3-hour wait. I was like, damn, and my clinic is a 2-hour drive from me. So it's an all day thing when I go there.
Yeah.
Okay, what would you think? I would think most Larrys you see are frustrated or angry for, say, like a tep leak or swallowing issues. How do you diffuse that kind of situation? And what do you recommend to other SLPs and Larrys as well for dealing with bad side effects and general issues?
Yeah, well, a lot of the or the issues that you're saying are not that they're expected, but they're pretty common. So to you as a laryngectomy, you don't know that anyone else has this problem, right? So kind of reframing it like, actually, we know that the prosthesis is eventually going to leak. They're not made to last forever. So that will happen at some point. We expect you to leak through. If you're leaking around, there's a few things we can do, kind of, just talking through like the problem solving and also the expectation, right? So when you say leak, I'm not sure if you mean like right after surgery, we're also looking for leaks.
You'll see people complain and like, well, it keeps leaking and blah, 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 like that
Oh,
kind of
yeah,
thing.
yeah,
And they
yeah.
get frustrated and then you'll see them get mad about the SLP. And I'm like, well, your body's different than everybody else's. They got to figure it out,
Yes, yes. And there are specialty prostheses that try to address some of those issues. Sometimes there's barriers for getting those prostheses though. So some of my patients would prefer to just stay with the prostheses that we stock in clinic rather than like purchasing a specialty prosthesis and bringing it to the visit. But there are options so I always talk to my patients about what their options are. So maybe something else will work better, or maybe it won't. What the research says, prostheses typically aren't going to last more than 3 months. So some people get 6 months, 9 months out of it, but that's pretty uncommon. So again, kind of setting what is the expected life of them.
Sure. Again, mine actually lasted, I think it was 11 months.
Yeah. Or even if it's somebody who's appropriate for a patient changeable, talking about if that's an option for them.
Doing yourself at home.
Yeah.
Okay, so what exactly is a fistula and how can you prevent it? What would you do once you get one?
Yeah, so a fistula usually would happen after, like more recent after surgery. So it's not as common that someone develops one, 10 years later, unless they're having other maybe problems going on, like another cancer, and then they're having cellular change, and then something happens and opens up. But usually it's right after the laryngectomy surgery, and patients are like, I want to eat right away. Well, it's a major surgery and all of that area is completely reconstructed and there needs to be time to heal. So we at our facility, we do pretty early. I feel like earlier than some other facilities might do check for if someone can return to swallowing and eating, or if there's a leak or a fistula. So a fistula is a hole that connects between two areas. So if you can have a hole through your cheek, right? So you think of the inside of your cheek to the outside of your cheek, right? So it's going through there and connecting those two. So you could also have one through the new pharynx or the neopharynx out to the skin. And that's what I think you're referring to.
Yeah. I totally had it spelled wrong over here.
Yeah, it's okay. So when that happens, you just need more time to heal. If it gets infected, you'll probably need to be on antibiotics, depending on the size of the opening. The ear, nose, and throat doctors might pack the fistula with some materials. But usually, and I actually even had a patient just this week that he was 2 weeks out from radiation, from the laryngectomy. He'd had radiation before the surgery. So we know it takes more time to heal when you've had radiation before the surgery. And unfortunately, it wasn't a fistula all the way to the skin, but there was a leak. So it hadn't fully healed. So he had to, continue with the tube in the nose, until it healed. So I talk about the good news. The good news is that we caught this early before you have a major infection. And what we can do about it is not have you eat and drink, because that food would sit there in that tissue and cause the infection. So we're catching it early. Let's let it heal up and then recheck.
Right, because food's got to go somewhere, and it's going to go wherever it can.
Right.
Okay, so somebody's prosthesis begins to leak. What are some of the tips that you give them to help prevent that? Because sometimes it's not a tep failure,
Right. Yes, that is an excellent question. So the first thing somebody should do if they have a voice prosthesis and it starts to leak is clean it. Maybe the little valve in there just has a little piece of food or a little something. It's a jar, right? If you clean it, and that can reset the valve. Some people use the brush, some people use the flush, and some people use both. What do you use?
Here's just a brush. I never got the flush with mine, so I've just been using the brush all the time.
Yeah, most of my patients just use the brush, but some people do have a flush and like to use that as well. So that would be the very first thing to do. The next, if it's leaking around, maybe just rotating it and making sure it's just not kind of cockeyed a little bit. Depending on how tight your prosthesis is, it might be very easy to, spin it around, or it might be a little more challenging. But those would be probably the first few things to try. If it's still leaking and it turns out, okay, this voice prosthesis is worn out, I'm going to need a new one. That's when you go ahead and use the plug, if you have a plug for your prosthesis.
Oh, I still have it. Yeah. Still got it here. My last episode kind of went over that. So.
Oh, perfect. Yeah. And those are hard because they're clear. Those little plugs are clear. So,
yeah. Yeah, like you're pretty much confirming what I said last episode, which is
I'll have to go back and watch it.
Okay, so other than chew more and swallow slower, what else do you recommend to prevent food getting stuck in the esophagus? And also, what do you recommend if food does get stuck in the esophagus? And fun question, would the Heimlich maneuver work on us?
Okay. So food sticking in the esophagus can happen for more than one reason. So it's not always the same reason. One reason might be if the esophagus, which should be a straight tube, if it kind of goes in and gets narrow in part, and then the food is collecting above it because it's too narrow. So when that's the problem, using a liquid wash, you take a bite, you take a sip, right, to try to flush it through. If it becomes just, really tight, then you might need to talk to your doctor about getting dilated or stretching that tissue out. But there's also many people that's not the problem. Their problem is food just sits in their esophagus and it just kind of sits there. So that's when there's a motility problem. It's not moving into the stomach. It's just kind of filling in the esophagus and sitting there. Or, that's where you get a lot of the reflux coming back up to your mouth. So letting gravity do its job. You have to sit upright. No drinking something and bending over to tie your shoe is going to come right back up, right?
You know how many times I forgot that?
Yeah. So giving it that extra time, and gastroenterologists might have a few things to do, but I feel like that's actually the harder one to solve than there being the narrowing or the stricture, is when it just kind of sits in the esophagus. Yeah.
And would Heimlich maneuver work on us? Would there be enough air pressure in our stomach to be able to do that?
So a Heimlich maneuver is to eject air up, right? So where's your air tube?
Right. That's what I'm saying.
So if you have something stuck down your stoma,
it's just gonna bring it out.
Maybe a Heimlich would get it out your stoma.
Okay, I get what you're saying.
It's not going to bring things up your esophagus, maybe it would make you vomit. I don't know, but no air, so there's no passage for air to come up though to blow it out, right?
Right. I figured maybe if you could squeeze it out like a burp, something weird. I don't know. Okay, it was just a fun question.
Yeah.
Okay, how often should somebody clean their stoma? And do you cringe sometimes when you see how we do it?
I don't. I have a good stomach. It doesn't bother me. I'm first to jump in if I take someone's Lary tube out and it's full of mucus. I'm like, oh, I'll clean it for you. You know,
No. I mean cringe, like you see the way we do it. Like,
oh.
yeah.
Well, people are on good behavior in front of me. So usually they're doing it the right-ish way.
Right.
But I have seen people like put their Lary tube in their mouth to wet it and then put it in.
Right.
But as far as how often, it depends on how much mucus you have. So, I mean, at least once or twice a day. But if you're someone who has mucus throughout the day, you'll probably have to clean it, more often. I do have kind of a fun story about one individual that I work with that it's not when he's cleaning his stoma, but he fishes and he doesn't wear filters. So he doesn't wear the HMEs. And he tells me, oh yeah, I fish, I cut it up, and then I'm talking. And he wonders why he gets pneumonia all the time. He's putting fish guts in his windpipe.
Right. Oh man, I don't even dare to work on my car half the time because I'm like afraid to get greasy and like be like, that's gonna be the time I need to mess with it. No, that's funny, man. Okay, let's talk about the products here for a minute. There's a few different brands for things from the EL to the TEP. Can you tell me which one you prefer, if any, and why? And or are they all patient to patient like everything else dealing with a Lary?
Yeah. So we have our typical go-tos, if you will, that we usually start with, but then based on somebody's need, if we can vary from that. So kind of our starting point for an electrolarynx, we usually like the True Tone electrolarynx. That's a pretty good one. So that's kind of a go-to. Now they have, the fancy emote. So they have, different versions of the True Tone, but that's a good electrolarynx. And then as far as the prostheses, in our facility, we use a lot of the Vega, the Atos Vega prostheses, but we do also carry the InHealth, like the classics, the also like the low pressure, which are the patient changeable ones. And then the Atos changeable one is called the NID. So those are the ones that we stock that are kind of our starting point. And then if somebody needs something, a specialty, something different, then we can talk about those options.
Right. The ones that you can change yourself, like, do you have to qualify for that? Like, is there a reason why you wouldn't be able to do that, for example?
Yeah, so not a lot of people can't do it because of their tissue could be one reason. So there's only certain sizes that the patient changeables come in. So for anyone who's in a 22.5 French prosthesis, they just because of the size of their prosthesis, they couldn't do it patient changeable. The patient changeable prostheses also have a smaller esophageal flange. So if you're someone who's at risk of dislodging the prosthesis, it coming out, has that ever happened to you? Have you ever had it come out?
Not yet.
Then you wouldn't be a good candidate for a patient changeable. So there's some reasons like that. And then there's also other reasons like vision, dexterity, if you're doing it on yourself. So anybody that I set up to do their own, they've done it a few times with me in clinic. I make sure they're comfortable with it. They're a good candidate. So it's not everybody can do it. But I will say 20 years ago, many more patients were doing it and it was kind of the go-to. And nowadays it's more common to say, oh, we'll just do it in the clinic. We'll do this kind. So if you're somebody watching this and you wonder if you could change it yourself, talk to your speech pathologist about that option.
Right. And I imagine they started doing it in the office because there was probably a lot of bad outcomes. Because I know I get dumb at times. I could picture me getting dumb then too. So
Yeah.
okay, biggest debate always seems to be how long you can effectively use an HME, or can you wash them and reuse them? So I've always frowned on the wash and reuse thing, but
I would say do not wash and reuse. If you're going to wash and reuse, don't even use it. And the reason is, if you think about the filter, right? If you're washing it, you're putting water on that filter. Now it's wet. What does something wet and dark, because it's right, it's in here, like on the backside, it's gonna, bacteria breeding ground, right? So and then you're breathing in what that bacteria, what you're breeding there. So don't wash it and reuse it. It would be better to, instead of using it for 1 day, use it for 2 before you change it, but I wouldn't wash it.
right. Like, what's the longest you would recommend wearing it though? Like, the recommendation is 24 hours.
The recommendation is 24 hours. So that is what I recommend.
That's what she recommends.
But if you used it for 48 hours, would something terrible happen? No, probably not.
Right. The way I'm looking at it, as long as you got it covered, cleanly covered, like, don't be grabbing any, garage rack, wrapping around your neck or something. But let's see. What are some of the products that Larrys should avoid using around their stomas, such as lotions and sprays and such?
That is a fantastic question. So do not use anything oil-based, because you don't want anything oil-based to end up in your lungs. Your lungs can't work it off. So you would want to use anything water soluble. That's perfect. So if say it's hard to get your Lary button or your Lary tube in, you want to get something water soluble as a lubricant that you can wipe on it and then just put it right in. That would be like KY jelly. You can get that at your local grocery store. That's water soluble, but that's a good point to bring up.
I tried avoiding any kind of suntan lotions or anything like that around there.
Yeah.
Like, I'm even careful when I go to shave. I don't want any kind of. So let's see, where am I here? Okay, some people will break out using skin barriers and using the removers. How are some of the ways they could try to prevent the outbreak, and how can they treat it when it does occur?
Yeah, well, the skin barrier should help the skin not having a reaction to it. So if you're not using a skin barrier and having that reaction, I'd say try to use a skin barrier and see if that helps. Other than that, there are base plates that are made for sensitive skin. So that is another option. The Optiderm is one that is for sensitive skin. Another thought is to take a break. You don't have to have a base plate on all the time. You can wear a Lary tube as long as it's fenestrated. If you have a prosthesis, you can still talk with it, or get a Lary button, so that you have options. You can give your skin a break so it heals properly, rather than just, kind of re-irritating it with a new base plate each time.
I try to get a day off. Like, usually Sunday's the day I don't wear anything. I just put a bandana and I don't leave the house.
Yeah.
So that way I just give my skin a chance to heal up.
Yeah.
Okay, what is lymphedema, and how can we prevent, or what just happened?
Lymphedema?
Yeah. What is lymphedema, and how can we prevent and treat?
Yeah, so lymphedema is also very common after radiation and surgery in this area, including with laryngectomy. So that's where the lymph fluid fills, and usually it's submental, we call it, which is right under here, but it can be even up into here. I've seen it in the cheeks for some people. So that's where the fluid that was circulating very easily before your surgery Now the pathway it used to go is interrupted, right? Because maybe you have a scar there, or, you know, they removed a bunch of lymph nodes. Very common to remove the lymph nodes. So the fluid is not circulating through your body the same way, and it can just kind of build up. One telltale sign is it's worse when you wake up in the morning, but it gets better through the day. And that's because when you wake up in the morning, you've just been sitting still all night while you're sleeping. And then through the day, you're walking around, you're helping things move in your body. You're talking, hopefully. So that's even moving your mouth. If you watch my mouth when I'm talking, there's small movements happening in my lips, under here. So that would even, that small of thing would help circulate some of the fluid. And then your second part to the question was, how can you treat it?
Yeah, what if you get one, how can you treat them?
Yeah, so there are certified lymphedema therapists, would be like the formal way to go, and they can teach you how to do some special massages. They can get you set up with wraps, so kind of like a wrap around here to compress, a compression wrap. So those would be some of the things that you could do. But then just even on your own, if you're like, it's not that bad, but can I just do something, right? Like I said, when you're trying to talk, if you're mouthing words, say you're using an electrolarynx and you're mouthing words, that's moving here. So doing as much movement, right? Getting things moving around. Also light massage to kind of break it up. It should never hurt. It should not be painful at all. If there is pain and you're like, oh, this hurts, it's swollen and it hurts, you need to show that to your ear, nose, and throat doctor. Lymphedema shouldn't be painful. It should just be like, feels heavy, it's swollen.
Right, almost like a numbing type thing, like a scar tissue almost. Okay, can we demonstrate some neck exercises real quick?
Just simple, when you think of a neck exercise. So turns this way, right? So you're stretching all along here. You're getting some movement in there. You can turn this way, side, head to shoulder.
Oh, yeah, just cracked my neck. That was nice.
That feels good. Yeah. And then you can even do some mouth movements if that lymphedema is kind of right around this area. So big smiles. And then ooh, type of movement to get the lip area. So you can also do some like chin tuck. Right, to kind of compress along here.
How important are the exercises, and how often should people continue doing them, like throughout the rest of their life?
Yeah, so that's the thing with lymphedema. It's treatable, but it's not curable. So that lymph fluid can continue to collect. So it's one of those, okay, I've done all the massages, I've worked with my therapist, I wore the compression, you go to bed the next morning, oh no, it's the same way again, I got to start all over, right? So it is something you have to keep doing. It can kind of come back, that swelling, just because more fluid is building up. So yeah, you do kind of have to keep doing it.
So don't treat it like it's the first of the year and you're making a resolution.
Oh, right.
You gotta stick with this one.
Right.
Okay, it seems that SLPs in the oncology field is lower than the other fields. Why is that? Is there just not the same centers and draw for, like, say, working with children or elderly?
Yeah. So if you were to, I don't know the numbers, so I'm just kind of ballparking it here, but if you think of, well, how many speech pathology job openings are there even? The schools is going to be, there's a lot of jobs in the schools because there's a lot of schools. There's a lot of children that have trouble talking or reading and writing, those areas that a speech pathologist works with. I tend to feel like there's a lot of laryngectomies, but that's just because I work in a very specialized area, right? So and I wish I knew offhand the statistics, but laryngectomies are really uncommon, really uncommon. If you go to the hospital, your nurse has probably never seen someone with a laryngectomy before.
I'm actually setting something up with my local hospital's ER because they've never seen anybody like me. So.
Yeah. So there's not as big of a job market for it because it is a specialized area. And then you need to have special training. So someone who is willing to do that extra effort for the training or has an opportunity for it and a desire, you know, not all speech pathologists want to work in this population. I love it. And I don't really want to work with children, but a lot of people feel differently. So it's also, most of the head and neck speech pathologists are tied to a larger medical center where they're doing the laryngectomy surgeries at that center.
Right. I don't think I asked you this earlier. Like, what kind of schooling is it? Like, how long of a schooling is there just to be a regular like school SLP?
Yeah, that's a great question. So 4 years of undergraduate degree, and then a graduate program is 2 years, and then we have to do a clinical fellowship. So that would be 7 years for a school-based.
So pretty much a doctor here. You
It's a lot of years, yeah.
Yeah.
And that's the same for a hospital SLP, would also need to do at least those 7 years. I'm crazy, so I got my PhD also. So I did 4 years in addition to that. But
Right. And so what are SLPs doing to help raise awareness? And what can we ourselves do to help raise awareness for head and neck cancer? Being that it's April, Head and Neck Cancer Awareness Month and all.
Yeah, that's perfect. So, well, I think what you just mentioned about going to your local emergency department and educating them, that is perfect. That's exactly what is needed. Emergency rooms, that is like, it's very scary, as I'm sure you know, hey, if something happens, you're going to go there for help and you know more about your condition than they do, right? So I think that is a great one. What we did, I think, you probably saw on Facebook, but this year was actually our first, but we want to do it annually now. We had a head and neck awareness event, and our ENT surgeons and the residents provided head and neck cancer screenings. So they did free screenings for people. And then we had a walk to raise awareness. I think I've seen some things posted about, hey, it should be in the news. So I think that would be a great avenue. If there's people listening to this that have connections to news networks, I think that would be fantastic. Hey, run a little something on head and neck cancer. There's some great statistics that could be shared. Very simply, hey, if head and neck cancer is caught early, it's the chance of survival is really high, and this is what you need to look for. I mean, there's a lot of awareness that can be done, but we are kind of the ones that have to do it, right? So you might think, well, gosh, I went through this surgery and I've had this. Other people should advocate, but you're the best advocate for the condition because you have it. So, and then speech pathologists, we love to advocate for things. So we're happy to be by your side and help you with that.
I've actually spent this entire week and like emailing news outlets. I got in trouble on Twitter because I was spamming and bullying news outlets. And I haven't heard anything back from them. It's kind of sad. Like, I don't know. I get it, but 4% of all cancer is head and neck cancer. And it's not just Larry's, So I think it's important enough to share the wealth. Okay, how much has changed since you started in your field, and where do you see it going in the future?
Yeah, I think some of the big changes have been technology. So when I first started about 20 years ago, we service the same, for the most part, the same populations of patients, but we focus more heavily on our clinical assessments, whereas just like with your ear, nose, and throat doctors, they're probably using more imaging studies, right? MRIs, PET scans, whatever. So also in speech pathology, we're using more of those X-ray swallow studies that we were talking about earlier, different types of exams. So our field has kind of gone toward relying more on getting those types of tests to help guide us. And I would think that would continue. One area, when we think of neurology, so speech pathologists work with a lot of stroke patients, but there's all of this neuroimaging that can be done. So then seeing what part of the brain lights up as you're doing this or that activity. So I think technology is probably what will continue to change the most.
I'm happy for it, man. Science is amazing, and it just keeps getting more amazing every day. So that was actually all the questions we have for this, and I appreciate you for coming on.
My pleasure.
And it's been awesome talking with you today. Well, there you be, guys. Hopefully you got a lot of information out of that. I want to thank Kerry again for coming on. I apologize again for not being on my A game. Not that I ever am on an A game. Anybody that ever watches this knows I butcher her English language every day, all the time. You should see my poor wife, especially since she's kind of a grammar Nazi. I drive her fucking wild, man. It's a good time. Sometimes I just make up words just to see her cringe. It's fun. So with all that said, as you heard, we're rare. We're a rare breed. But we deserve to be heard just like anybody else. So I encourage anybody that is a laryngectomy, knows a laryngectomy, a fan of this, whatever, contact your local news outlets and get the word out, man. Because the only way awareness is going to be raised is if we do something. And I can only do so much. I need your guys' help, to help me, help you, help them. You know what I mean? Yeah. One person's not going to start a movement, I don't think, but I'm trying my ass off. So contact your local news outlet, your local newspapers, all that good stuff. Post it on all your social media. Get the word out that it's our goddamn month and we deserve to be heard, even if with a low voice. All right, guys. Go get the book. A silent partner. My first year is a laryngectomy. We might send you some stickers for your HME. You can find us on Facebook at Lary Talk, the Facebook page. You can find Lary World, which is the group about the page. You can post anything you like in there, memes or whatever, as long as it's not religion or politics. We want to avoid that. And no magic elixirs or any of that. You'll get banned. You can also find us at Lary Talk on TikTok, where I'm posting tips, awareness, general jackassery, being me. Some of it's fun, other of it's educational. It's a little mix of both, trying to get all the audience, And of course, you can go to LaryTalk.com. If you go to our help and support section on LaryTalk.com, you can actually find help and support in your area. Or online, you can help you find insurance, supplies, support groups, all that kind of stuff. So not only are you getting the latest episodes and all that good stuff, you can get some help up on there too. And if you would ever like to contact me directly, you can go to LaryTalkPodcast@gmail.com. That is the email for our show. And I'm pretty quick at replying back, goes right to my phone. So if you want to contact us for any reason, there you go. Also, keep a lookout. University of Rochester did a little blurb on me for their Facebook page and their Twitter accounts, or all their social media, really. And it's all about the show, my little journey, why I'm doing the show, that kind of stuff. So keep a lookout for that. I'll have that up on the Facebook page. It's kind of cool. Same time, it's like it's a nice little brag on me, but I'm not the kind of like brag about myself. I'm more looking at getting the exposure, to getting the word out, to getting awareness. So But look for that in the meantime. And that's it for this week, folks. Thanks for joining me. And tune in next time. We're going to be talking about supplies, I think. So until then, take care of yourself and have a good one.
Everybody wake up. It's a brand new day, and this is your chance to let your soul shine. Proud to be you and me, freaks and geeks. Always remember that your soul is divine. Come on. When the road resting, when the sun sets, we bust out paint and make a big mess and take a big breath, cause the air is fresh. Like, man, this world here sure is beautiful.